Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 510 of our pharmacotherapy series, which majors in chronic kidney disease. This case applies to patient GBS in parts 508 and 509 of this pharmacotherapy series. GBS has a serum potassium concentration of 5.3 milliequivalents per liter. I would like you to describe the mechanisms by which potassium imbalance occurs in patients such as GBS who have progressive chronic kidney disease. Hyperkalemia can result from a combination of factors, including diminished kidney potassium excretion, redistribution of potassium into the extracellular fluid owing to metabolic acidosis, and excessive potassium intake. In patient GBS, all these mechanisms are likely to be contributing to hyperkalemia. Potassium normally is filtered at the glomerulus and undergoes nearly complete reabsorption throughout the kidney tubule. Distal tubular secretion is the primary mechanism by which potassium is excreted in the urine. A variety of factors affect this distal secretion of potassium, including aldosterone, sodium load presented to the distal reabsorptive site, hydrogen ion secretion, the amount of non-resorbable anions, urinary flow rate, diuretics, mineralocorticoids, and potassium intake. 0.8 Serum potassium concentrations are relatively well maintained within normal limits in patients with CKD. At eGFR greater than 10 ml per minute per 1.73 meters squared, hyperkalemia is rare without an endogenous or exogenous load of potassium. This balance is maintained despite a decreasing nephron population and an overall drop in eGFR, because the remaining nephrons undergo adaptive changes to enhance the distal tubular secretion of potassium per nephron, i.e., increased fractional excretion of potassium, abbreviated as FEK. GI excretion of potassium is also important because increased GI excretion and fecal losses may account for up to 35% of the daily potassium loss in patients with severe kidney disease. Patient GBS's eGFR of 21 ml per minute per 1.73 meters squared is above the threshold value for adequate potassium homeostasis. Patient GBS should be carefully observed for manifestations of hyperkalemia as her kidney disease progresses. Additional factors that alter potassium homeostasis include metabolic or respiratory acidosis. Acidemia can cause a redistribution of intracellular potassium to the extracellular fluid. Patient GBS has metabolic acidosis as indicated by serum bicarbonate of 18 milliequivalents per liter. This condition may account for her mildly elevated potassium concentration. Correction of metabolic acidosis could lower her potassium concentration. For each 0.1 unit change in blood pH, an inverse approximately 0.6 milliequivalent per liter change in the serum potassium concentration occurs. Patient GBS is not taking any drugs that could contribute to hyperkalemia, although the influence of angiotensin-converting enzyme inhibitors and angiotensin II receptor blocker must be considered because they are now advocated for GBS to delay progression of kidney disease. Potassium-sparing diuretics triamterone and amiloride should be avoided and spironolactone used with caution in patients with severe CKD because they decrease tubular secretion of potassium. The next question reads, is treatment of GBS's potassium indicated? How should severe hyperkalemia be managed? Treatment of hyperkalemia depends on the serum concentration of potassium as well as the presence or absence of symptoms and electrocardiographic changes. Manifestations of hyperkalemia include weakness, confusion, and muscular or respiratory paralysis. These symptoms may be absent, especially if hyperkalemia develops rapidly. Early ECG changes include peaked T waves, followed by decreased R wave amplitude, widened QRS complex, and a prolonged PR interval. These changes may progress to complete heart block with absent P waves and, finally, a sine wave. Ventricular arrhythmias or cardiac arrest may ensue if no effort to lower serum potassium is initiated. However, with a potassium level less than 6 milliequivalents per liter, GBS is unlikely to be experiencing ECG changes. GBS has a mild elevation in potassium to 5.3 milliequivalents per liter. Therefore, no specific treatment is required. Generally, treatment is unnecessary if the potassium concentration is less than 6.5 milliequivalents per liter and there are no ECG changes. Although this serum potassium concentration does not require immediate intervention, close monitoring for hyperkalemia and its manifestations is necessary. This would be particularly important after starting angiotensin-converting enzyme inhibitor therapy, which can contribute to development of hyperkalemia by decreasing aldosterone production. If potassium concentrations rise above 6.5 milliequivalents per liter, and especially if they are accompanied by neuromuscular symptoms or changes in the ECG, treatment should be instituted. Goals of therapy include prevention of adverse events related to excessive potassium and reduction of serum potassium concentrations to a relatively normal range. Chronic management involves prevention of hyperkalemia by limiting potassium intake and avoiding the use of agents that could elevate potassium levels. This requires regular monitoring of potassium concentrations. Acute management involves reversal of cardiac effects with calcium administration and reduction of serum potassium. The latter can be achieved by shifting potassium intracellularly with administration of glucose and insulin, beta-adrenergic agonists, or alkali therapy, if metabolic acidosis is a contributing factor, and by removing potassium using exchange resins or dialysis. My next question to you reads, assess patient GBS's acid-base status. How should her acid-base disorder be managed? Patient GBS's low blood bicarbonate content and high chloride concentration are consistent with metabolic acidosis. Normal buffering of hydrogen ions by the bicarbonate carbonic acid system as well as other extracellular and intracellular buffers, including proteins, phosphates, and hemoglobin, is essential for maintaining normal acid-base balance, i.e., normal pH. Normal metabolism of ingested food produces approximately 1 milliequivalent per kilogram of metabolic acid daily, which must be excreted by the kidneys, primarily as ammonium ion, to maintain acid-base balance. The kidney is responsible for reabsorption of bicarbonate and excretion of hydrogen ions through buffering by ammonia, produced by the kidney, and filtered phosphates. Reduced bicarbonate reabsorption and impaired production of ammonia by the kidneys are the major factors responsible for development of metabolic acidosis in advanced kidney disease. As nephron function declines, production of ammonia is increased to compensate for a decrease in secretion of hydrogen ions. However, once the maximal capacity for ammonia production is reached, acidosis develops. Mild hyperchloremia is generally observed in the earlier stages. As kidney disease progresses, metabolic acidosis with an elevated anion gap is observed owing to accumulation of organic acids. Bone carbonate stores serve as a source of alkali, but with time cannot compensate for changes in acid-base balance. Metabolic acidosis can contribute to bone disease by promoting bone resorption, and it may also influence nutritional status by decreasing albumin synthesis and promoting a negative nitrogen balance. Patient GBS's mild acidosis should be treated with a goal of normalizing the plasma bicarbonate concentration or at least achieving bicarbonate levels of at least 22 milliequivalents per liter. Treatment includes use of preparations containing sodium bicarbonate or sodium citrate. Each 650 mg tablet of sodium bicarbonate provides 8 milliequivalents of sodium and 8 milliequivalents of bicarbonate. Scholl's solution and Bicitra contain 1 milliequivalent of sodium and the amount of citrate or citric acid to provide 1 milliequivalent of bicarbonate per milliliter. These latter agents may be used in patients who experience excessive GI distress with sodium bicarbonate because of production and elimination of carbon dioxide. If a patient such as patient GBS is sodium and fluid overloaded, it is important to consider that sodium bicarbonate can exacerbate this problem. Polyketra, or potassium citrate, is a possible alternative. However, the potassium content limits its use in patients with more severe kidney disease. Citrate also promotes aluminum absorption and should not be used in patients taking aluminum-containing agents. The amount of bicarbonate supplementation to achieve a bicarbonate of 22 milliequivalents per liter can range from 0.3 to 1 milliequivalent per kilogram per day. Typical starting regimens can be 2 to 4 650 mg sodium bicarbonate tablets per day, divided into 2 to 3 doses. Afterwards, doses should be titrated to desired bicarbonate levels. Equations based on the serum bicarbonate level are available if an immediate correction of the metabolic acidosis is warranted. Once dialysis therapy is initiated in patients with kidney disease, IV and oral supplementation with bicarbonate or citrate or citric acid preparations is generally not required. At this point, dialysis therapy is used to chronically manage metabolic acidosis through use of dialysate baths containing bicarbonate. Bicarbonate is added to the dialysate solution and is delivered through the process of diffusion from the dialysate bath into the plasma. If dialysis therapy is initiated in patient GBS, the continued need for oral bicarbonate supplementation should be reassessed. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 511.